This is Selma Schimmel reporting for the Group Room at AACR, the annual meeting of the American Association for Cancer Research in Chicago. Happy to be joined now by Dr. Patrick Hu, Department Chair in the Department of Melanoma Medical Oncology, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Hi, Dr. Hu.
Hi, thanks for having me today, Selma.
Let's talk about the treatment modalities that are available for metastatic disease.
Once the disease has spread, we do a number of things. There are a lot of cutting-edge clinical trials, and in the last year, after over 20 years with no new drug, there have been 2 new drugs that have been approved for advanced melanoma. One of them is a targeted therapy that targets mutation called B-Raf. We can think about these mutations as light switches. If those light switches are flipped on, some of these pills can flip those off.
These are oral compounds.
They're oral medications taken twice a day. And so about half of the patients have the right kind of light switch called a B-Raf mutation that would match our pill that can turn off that light switch. And patients can have dramatic responses. They're not often durable, but they can have still dramatic responses that last at least around 7 months on average. The other drug that's very exciting is called Yervoy, which is an immune agent stimulating the body's immune system. It takes the brakes off the immune system. It's an antibody infusion given every 3 weeks, and it stimulates and activates the body's immune cells to then go fight the cancer. The response rate is on the low side about 10%, but the good news is that some of the patients that are treated with advanced cancers have their disease go away and stay away forever. And we've put patients on over 10 years ago when I was at the National Cancer Institute, and some of those patients are still doing well today.
How is that therapy delivered?
Intravenously every 3 weeks.
And side effects?
The side effects that it can stimulate your body's immune system, you get immune toxic side effects. The most serious is colitis, which would be manifested by diarrhea. You can also get skin rashes, and you can also get an immune attack of some of your endocrine organs, one called the pituitary, but that is, as long as it's caught early, it can be easily remedied by getting hormone replacements.
And what about the B-Raf immunotherapy side effects?
Generally, that's fairly well tolerated. We can get some issues with the skin. The most serious is that it brings out squamous cell cancers that were probably harboring there, but it helps them grow. And so a patient on a B-Raf inhibitor needs to see a dermatologist. After about 8 to 12 weeks, we usually see the squamous cell cancers that are growing and can cut those out and usually have very minimal adverse effects, but we do need to have close collaboration with dermatologists.
How do you determine if one has the B-Raf mutation?
It's done by taking the tumor samples and isolating the DNA and then sequencing that DNA to know if that light switch is turned on or not. So it's from the DNA from the tumor biopsy.
So if a patient does not have the B-Raf mutation, you would then treat them with the Yervoy?
Yes, we would treat with the Yervoy to try to stimulate the immune system. There are other agents that we could treat with, one called interleukin-2, which is a natural protein that stimulates the body's immune system. Again, the response rates aren't that high, but some of the patients are cured with these immune therapies, and so that's why we want to always try them. There are other investigational agents that are very exciting, such as our T-cell therapy.
And would you ever integrate all of these therapies together?
Yes, I think it's very important, and that's what I actually spoke about today at our conference, which was combining targeted therapies plus immunotherapies. And I think there's significant potential because our targeted therapies that turn off the light switches, we have a very high response rate, over 50%, but they don't last very long. And the immunotherapies have a low response rate, but they can last forever. So putting them together, hopefully we'll get the best of both worlds. And there's a lot of scientific rationale now that those two will work very well together.
What kind of survival outcomes have you seen with the therapies?
For the targeted therapies, patients with advanced melanoma, the median survival is just reported to be about 15 months. With Yervoy, if patients don't respond, they're not going to have an increased survival. But if they do, there is increased survival overall if you compare the patients who get Yervoy with those that don't. And if they do have a great response, that can last for years and years and years, and they can have survival over 10 years or longer. And so that's what we call the tail of the curve, the tail of survival. That's where every patient wants to be, is essentially cured with long-term survival. And I think we can get there with even more patients. For example, we're doing a therapy called T-cell therapy, where we're taking tumors to our laboratory and trying to isolate the immune cells called tumor-infiltrating lymphocytes, or TIL. From those tumors, we grow them up to billions and we give them back. And in patients who receive that therapy, we can have response rates of about 50%.
Is Yervoy the trade name or the generic name?
Yeah, there's so many names for these drugs. Scientifically, it's anti-CTLA4, for cytotoxic T lymphocyte antigen 4. So that's what scientists will call it. And then it was called ipilimumab for a while, and then once it got approved, they changed it to Yervoy, which I think sounds like a Russian spaceship, but myself did.
Any last thoughts that you'd like to share about the future of melanoma research?
I think it's very bright. We had a period of time when everyone was working extremely hard, but we had no new FDA-approved drugs for over 20 years. That was frustrating in the clinic. But now we have 2 new drugs, and one a targeted therapy, one an immunotherapy, and now that's the tip of the iceberg. The pipeline is healthy. We have many new targeted therapies and immunotherapies, and we just have to move as fast as we can, because if you ever come to clinic with me, you'll see these patients and their families want us to move quickly with urgency, and that's what we should do. And I'm optimistic that we're going to be able to solve this issue in a few years and hopefully take what we've learned from melanoma into other kinds of cancers and learn to treat them as well, such as colon cancer and lung cancer.
And I imagine these new successes as sort of kind of a fuel and an inspiration to move forward, because it had been so long since you'd seen some positive results in the lab.
I think it's inspired the whole community.
Thank you very much, Dr. Patrick Hu, Department Chair, Department of Melanoma Medical Oncology in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas.
Thank you for inviting me.